This episode of Us and Them is supported with a grant from the Claude Worthington Benedum Foundation.
Hey, it's Trey Kay from West Virginia Public Broadcasting and PRX. You're listening to Us and Them, the show that tells the stories about the things that divide us. I'm in Fairmont, West Virginia. It's a city of about 18,000 people in the northern part of the state. For decades, Walmart and Fairmont State University topped the list of the area's largest employers. Also, a big source of jobs around here was the Fairmont Hospital. It's a building that's changed its shape and its size, and it's had a lot of different names and owners over the years. But it's always been Marion County's only hospital. And in 1962, I was born right here in this building. My parents were living here in Fairmont. My dad was in law school nearby, and my mom was a pharmacist near here. After graduating, my parents planned on moving to Charleston. But the timing was tight. My dad's graduation was in May, and my mom was pregnant and due in June. Her doctor didn't think it was such a good plan for her to be moving. So we stayed a little bit longer here in Fairmont, and my brother was also born right here, Fairmont Hospital. There's been a hospital in the city since 1904, and the community resource has been at the center of many family birth stories like mine for generations. But just a week after the president declared a national emergency from the coronavirus, the hospital shut down.
Amanda and Dawn, at about noon today, Fairmont Regional employees started to be dismissed by department immediately following the final 2 patients that will ever be cared for at Fairmont Regional Medical Center.
When it closed in March, the hospital was owned by California-based Electo Healthcare Services. The company reports it had to close the facility because it was losing money, $19 million over a 3-year period. The company said it couldn't find a buyer or work out the financing to keep the hospital open. 550 people who worked at Fairmont Hospital lost their jobs. And Marion County's 56,000 residents lost their only hospital. A few days after the hospital closed, an 88-year-old African-American woman from Marion County came down with COVID-19. She was hospitalized, not minutes from her home, but in a neighboring county, about a half an hour away, where healthcare options are more plentiful. She later died as West Virginia's first coronavirus fatality. 2 other hospitals in the state have closed this year. Like Fairmont, they were struggling before the pandemic, but the financial pressures of the coronavirus contributed to their demise. Healthcare is a big business in this country, and rural hospitals are especially vulnerable to market forces like population losses and economic pressures. More than 170 rural hospitals are gone nationwide. That's according to the Sheps Center for Health Services Research at the University of North Carolina. Its reporting also shows the vast majority of those hospitals, 130, shut their doors in the last 10 years. And in 2019, even before the pandemic, 19 rural hospitals closed nationwide. The coronavirus pandemic is putting our national healthcare system through a stress test like never before. Millions of healthcare workers have lost their jobs or have been furloughed. Health centers, clinics, and hospitals are at risk of closing their doors. Rural health systems may be the canary in the coal mine, showing us the weaknesses of our current system. Large healthcare systems have size on their side, but what about the small and medium facilities necessary for rural America? How will they survive at a time when patients are staying away from elective procedures and driving down business? During a pandemic, we need to know our healthcare will be there. This is particularly true in West Virginia, which has been crushed by the opioid epidemic and is statistically a state with an older and sicker population.
The pandemic has shown a bright and shining light, and it's acted as a magnifying glass on the fault lines in our systems of care, so that they're magnified now more than ever.
That's Dr. Mike Brumage. He's the medical director for Cabin Creek Health Systems. It's a community-based system serving people in the Charleston area and the greater Kanawha County. We talked at my mom's house in Charleston and sat on her back patio for a socially distanced interview. Oh, and I just want to mention that we took all recommended safety precautions for any interview that I did for this story.
The way we've done medicine in the past has been very expensive. It's been focused on the disease state rather than the prevention piece of this. And so we're bearing the consequences of that. And we are in a place where things are so broken that we are at risk of losing our healthcare systems to our most vulnerable people, specifically in rural areas.
Many in the healthcare industry say our current system, what's called a fee-for-services model, just doesn't work. During early coronavirus lockdowns, elective medical services, the bread and butter of the healthcare industry, things like knee surgery, hip replacement, or a colonoscopy, were declared non-essential and canceled. In just 4 months, this loss of revenue sent hospitals and health systems into a financial tailspin. The American Hospital Association estimates the 4-month loss from March to June is $200 billion. Even though cities and businesses are opening back up, many people don't want to risk getting COVID-19 at the hospital, so patients aren't rescheduling elective medical procedures. Dr. Brumage says this is a huge problem for the whole health system, which relies on revenue from patient visits.
It's damaging for the patients not to get necessary preventive care, but it's also damaging for the financial bottom line, which again, we lose those rural hospitals.
Right. If we lose that rural hospital, just walk me through what that future could be like.
So hospitals, by the way, are more than just places where healthcare is delivered. They are economic engines for their communities. They are the hub of highly paid, highly skilled individuals who then contribute financially to the communities in which they live. Now, that's sucked out of a community, and you take away the tax base of that community. People then no longer have access to healthcare in that town. They have to drive farther away. It just becomes this spiral of growing poverty in a community that ends up with fewer and sicker people.
One way many health systems and hospitals are able to provide patient care and keep some revenue coming in is with telehealth. That's holding appointments on a video chat or a phone call. Brumage calls telehealth a life raft.
Telehealth has been absolutely huge. Even when we cannot do a visual visit with a patient through a platform like Zoom or FaceTime or Skype, we can talk to people over the telephone, and we can learn quite a bit about how people are doing. We can find out whether they're taking their medications, if their health is improving or failing, whether we need to change something therapeutic-wise on those folks. We could not have survived this without the changing of the rules that allow us to bill for telehealth.
Because at the beginning of the pandemic, there was some initial concern that practitioners were not going to be able to bill for telehealth, right?
That is correct, and that changed. And now it's not the same as an in-person visit. I think it's at 55 cents on the dollar, but it's something. And what we hate to see, it's not about just us making money. It's about having to prevent laying off other people. You know, we're trying to keep the whole ship afloat, and you can't have a well-running ship without all the crew.
The vast majority of hospitals and health systems in the U.S. run on a nonprofit business model. Some nonprofit systems can actually be profitable, and we'll talk more about that a little later. But most healthcare nonprofits operate on thin margins. A few years ago, I met Martha Carter.
I am a certified nurse midwife and was in clinical practice for about 20 years.
She was also the CEO of Family Care, a community-based healthcare system she created in Putnam County 30 years ago to meet the needs of low-income rural women and families. When I visited Carter recently at her very rural home, she was at the backyard pool with her young grandchildren from New York City.
But it's a new experience for them. They're out here in the woods and learning about rural living.
Rural living is part of what's defined Carter's personal and professional life for nearly 4 decades. She and her husband built this house in the 1980s, right about the same time she started Family Care. It was part of her plan to provide health care for women who were too far away from bigger cities like Charleston. It quickly expanded to treat families. She chose a business model that would work for her patients, nearly all of them uninsured or on Medicaid.
The access to care for low-income women and their families was pretty lacking in this area. As we searched for models that worked, we actually tried a couple different things, but landed on the community health center model, which is just a fantastic model that a lot of people don't know about. It federally supported nonprofit organizations that are locally managed and governed by a board of directors that is a majority of patients of that health center. So there's
who
a
are
great
in the community.
Yes, so there's a great tie with the community. The board is very close to the community, knows what the needs are, can help advise the organization to make sure that they're filling the needs of the community. So the community health center model is very effective, and it was a great fit for what we were trying to do.
Carter retired from Family Care in 2019 and is no longer involved with the organization. But she says it did receive some federal stimulus money from the Coronavirus Aid, Relief, and Economic Security Act, also known as the CARES Act.
It was about a 2-week chunk of money. Any money is a help, of course, and it staves off closure and having to lay off staff, but I don't know how they're doing. I mean, it must be really tough right now.
Carter is now a consultant and still active in the healthcare industry. She serves on a national board that advises Congress on Medicaid and healthcare programs for low-income children. As Mike Brummage mentioned earlier, telehealth has been a saving grace for health systems that can make it work technically. Martha Carter has long been a proponent for telehealth as a way to serve rural communities. She wants Congress and state Medicaid programs to continue paying for telehealth and make it a permanent option for low-income patients.
A lot of the flexibility that's been put in place through the pandemic stops at the end of the pandemic, at the end of the public health emergency, or in some period of time, 30 days, 60 days, sometimes a couple months. So I'm actually really worried that a lot of the good things that have happened, the things that have really helped increase access in rural communities and disadvantaged communities are going to go away, at least for some period of time and maybe forever after the pandemic or after the public health emergency.
This public health emergency in many ways is something that's kind of bringing attention and maybe holding people's feet to the fire.
Well, we've had to be innovative and flexible and during the pandemic, and I hope we don't just go back to business as usual, because the healthcare system that we had, and we still have, but to a lesser degree, isn't really designed for people. It's designed for the healthcare system. It doesn't really reach a lot of people who need care.
Do you have any idea where we'll land in terms of getting back to a medical system that can tend to general care as opposed to just responding to mostly the COVID pandemic?
My hope is that as we've reported outcomes by race and ethnicity and really realize how badly the pandemic has affected communities of color, that all really sparks changes, not just in the healthcare system, but in our entire culture. I really don't know how this is all going to turn out, of course. I have strong faith in the community health center movement, for sure, because the health centers have always been open to everybody and serve a high proportion of low-income people, communities of color, migrants, immigrants. And so I would love to see the health center model expanded across the country. I think there's a lot of work to be done in the healthcare system to really ensure justice for all, and I'm not sure exactly how that's all going to happen.
The community health centers Carter advocates for are known as federally qualified health centers. They receive government funding and are required to serve everyone, regardless of their ability to pay. In West Virginia, 1 in 4 people gets their care from community health centers. These systems are struggling for economic survival, like all the rest. Increasingly, larger health systems in West Virginia are expanding their footprint into areas with small local regional hospitals and clinics. I asked Carter about that.
Well, we've gone through this cycle a couple of times. There is a good case to be made for care that's integrated so that when care is needed, there's a system past primary care of specialists and hospital care and rehab and residential care. The whole system needs to be well integrated. There's also, of course, a movement to reward healthcare systems for keeping the cost of care down while keeping the quality of care up. So one of the ways that hospital systems can do that, or any system can do that, is by controlling a larger share of the market and sort of vertically and horizontally integrating care. So it's understandable why that's happening. But you've heard me say that I believe so strongly in the community health center model. And so when a hospital system comes into a small town and puts a little clinic there and it's new and people go there, it winds up potentially weakening the community health center in that town and then makes it more difficult for that health center to provide the full range of services for everybody who needs it.
Coming up after the break, cooperation versus competition. What will it take for West Virginia's healthcare systems to make it to the other side of the pandemic?
We think going forward, to survive healthcare, you have to have scale. And we think to be relevant, you have to have that size to where you're probably in the $5 billion range.
There is a division between the poor people's clinic and the clinic that will serve the rich people, okay?
And we visit Mingo County to see how one provider is able to innovate while serving some of West Virginia's poorest and most vulnerable patients.
We feel that Williamson Health and Wellness is the economic driver for our city, and we're pushing to help develop more opportunities for the people that live in the area.
That's after a break. You're listening to Us and Them. This program is supported in part by the West Virginia Humanities Council and the CRC Foundation. This episode is supported with a grant from the Claude Worthington Benedum Foundation.
In difficult times, music gives us peace, brings us together, and helps heal us. It calms our nerves and brightens our days. That's why we're bringing you classic episodes of Mountain Stage on air and in our podcast. This is Larry Gross, host of Mountain Stage. Find something that's familiar or brand new and feel the power of live music on our website, mountainstage.org.
Hey, it's Trey, and this is Us and Them from West Virginia Public Broadcasting and PRX. We're talking about the business of healthcare during the COVID era. Hospitals and clinics across the country have lost staggering amounts of revenue and have cut millions of healthcare jobs. The American Hospital Association reports that hospitals face unprecedented financial pressures due to COVID-19. It says from March 2020 to the end of June, the country's hospitals and health systems have lost an average of $50 billion per month. And the virus continues to spread. With those massive losses, how many emergency rooms or specialty clinics or family doctors will be able to stay afloat? There are two cases that show how West Virginia health systems can help rescue rural hospitals and maintain service for a region. Remember Fairmont from the top of the show? It's the hospital where I was born that closed early on during the pandemic. Well, the massive brown building, designed for 200 beds, recently reopened. Sort of. A scaled-down version of it, a temporary emergency department, just 10 beds, is back in business. West Virginia Governor Jim Justice made a deal with West Virginia University Health System, known as WVU Medicine. The system will run a temporary ER in Fairmont as a branch of its flagship hospital in Morgantown, about a half an hour north. WVU Medicine is the state's biggest healthcare provider and largest private employer. As part of the new arrangement, WVU Medicine is committed to keeping a presence in Fairmont, but they're taking time to assess how that will be. Continue operating in the old location after some renovation, or build a new structure somewhere else in the city. As hospitals close at a fast clip, I wanted to know why WVU Medicine chose to save the day in Fairmont, and why it wanted to expand its brand there. A childhood friend of mine, Doug Kaufman, is the company's chief financial officer. He agreed to meet with me at the hospital in Morgantown, which is near the Pennsylvania border. I asked him to give me a snapshot of their financial situation going into the pandemic.
We are very strong financially. We are rated by both Moody's and S&P. We're A-rated with stable outlooks. We have, in 2019, just surpassed $3 billion in assets, $3 billion in operating revenue. And so we think going forward, to survive healthcare, you have to have scale. And we think to be relevant, you have to have that size to where you're probably in the $5 billion range.
Even though WVU Medicine is a nonprofit, Kaufman explains it still has to generate a profit to reinvest in capital projects, technology, and medicine.
Our margins are not big. They're generally in the 2 to 3% range. But if you aren't generating a margin, you aren't able to recruit the best talent, invest in the best technology, and provide the best care possible.
Still, Kaufman says WVU Medicine is not immune to the financial devastation of the COVID era. He says the health system has lost about $160 million so far.
In the 1st of March, we probably had average occupancy, just say on the inpatient side, of about 80%. That dropped down to below 50% in the month of April. Literally, we lost about 50% of our volumes.
Wow.
Well, when COVID first hit, leadership stepped up. And one of the advantages of being the scale of a health system that we are is we have reserves in the bank. We are fortunate, very fortunate. We realized we were in a position where we can weather a storm. And then when Congress stepped up and provided the relief funding, that made it that much easier.
WVU Medicine received $125 million in federal stimulus money to cover day-to-day operations. Kaufman says big banks also stepped up to help with a $100 million line of credit. He says the system hasn't had to use it yet. They put other cost-saving measures in place. Physicians and staff took pay cuts. There was a hiring freeze, but no layoffs. It sounds like that you were taking this all in stride, but I mean, were you sleeping well?
Well, yeah, because it's part of a whole team. And again, I can't overemphasize the fact that the scale that we have as 11 hospital healthcare system really brings to the game. If I was a small hospital, an independent hospital with no backstop, a small independent hospital doesn't have the ability to call up a United Bank, a Wells Fargo, or a PNC and say, hey, I need $50 million to maybe weather this storm, and get that. And so the scale of being able to do that and the strength of our system, people know West Virginia medicine is going to be here after this storm is over.
So how many pre-pandemic elective procedures are your facilities doing now?
It's hard to say. During COVID, we literally did not do 6,000 OR cases that we normally would have done. For whatever reason, either the patient figures out they can live with the pain, they find an alternative, or they just don't follow through with getting the procedure. We get 95% of those back, but you won't get them back day one. It will be over the remainder of 2020 that we recover those 6,000 surgery cases that didn't happen during COVID.
Before the pandemic, some WVU medicine offices were starting to see patients using telehealth. Kaufman says their strategic plan called for a 10% increase in telehealth services in 2020. That meant going from 15,000 telehealth visits in a year to 20,000. The pandemic blew that goal out of the water. At the start of the crisis, the system quickly invested about $2 million to ensure every physician across the entire system was equipped with computers and network technology to make telehealth work. Kaufman estimates the pandemic exploded telehealth use to levels that would have taken at least 5 years to achieve.
We actually went from, I think, about 1,000 of those encounters in February to over 50,000 in the month of April. At the beginning, we had physicians that weren't comfortable doing it. We had patients that weren't comfortable doing it. And by the middle of May, that completely flip-flopped. And so, like I said, it probably sped up the introduction of telemedicine in the state of West Virginia by at least 5 years. I think one of the things that became apparent during this crisis, and this is something that will really be dependent on the politicians in Charleston and Washington, is the emphasis on broadband has to improve. You can't rely on virtual visits in West Virginia if you don't have the connectivity.
Okay, so you're making telehealth available and trying to lobby for more connectivity in the state, but will you be closing brick and mortar facilities? Is that the kind of business bottom line that maybe some people might see in the future?
You could. I can't point to a specific location or example of that right now, but I think down the road, for us, it's about our goal of eventually lowering that cost of care. I think everybody will admit healthcare in the United States is 20% of GDP. That, in most people's opinion, is not sustainable. And so part of our long-term strategic plan is how do we lower that cost of care? And telemedicine and virtual visits is a way to do that.
The cost of healthcare is too high. Americans spend more on healthcare than most other advanced countries. In 2018, the average cost was $11,000 per person. The Brookings Institution reports that a third of all healthcare spending is paid to hospitals. Another quarter of that pie goes to clinics for outpatient care. That's what makes healthcare such a big business, and why it's now so vulnerable when patients don't show up. The jobless rate in the U.S. is about 10%. That's 30 million people out of work. In July alone, 4 million people filed for unemployment. Since health insurance is tied to employment, nobody can afford to get sick. And even post-COVID, when people can go back to the doctor, will they? it will take time for people's trust and for the economy to recover. This suggests that rural hospitals and healthcare systems that rely on private insurance are headed for continued losses. I asked Doug Kaufman what this could mean for a big player like WVU Medicine. For years, it's been expanding its footprint throughout the northern part of the state.
Our approach has been on a collaborative basis. In other words, in the rural places we've gone, I'll use Summersville for example. Summersville was struggling. They were on 1 day's cash on hand. We didn't go into Summersville to put Summersville out of business. We went into Summersville to help them be successful and provide care for that community. West Virginia only has 1.8 million people in the state, and towns like Summersville, Braxton County, Jackson General, those hospitals can't put specialists in those small towns. But what they can do is rely on us and refer those patients to our specialists when they're needed. And that creates the patient base that our physicians need so that we can become that patient hub.
Well, let me put it to you this way, Doug. I guess one of the things that I'm hearing worry and concern about is that if a large institution like WVU Medicine were to expand its footprint into a place that maybe has, a small hospital, maybe a community healthcare system, and they would see this institution moving in as competition, and that more people would flock to that, and maybe eventually these community healthcare systems would basically dry up, maybe go away.
Yeah, that's not our model. I don't think of the 11 hospitals that are part of our system, you could point to a single one of those that we did that. In the ones that we've put services in, we've done it where the community has asked us to and where the need has existed.
I just want to push on this one thing. The negative would be if the larger institution was to move into the area and then eventually, if you would consider those other people competition, they go away. It's almost kind of like a Walmart moving in. And
I agree.
And then eventually Walmart does a reassessment. And, it's the store here in Tucker County is losing money. Let's just pull it out. And then all of a sudden you're in a kind of a...
Then there's a hole.
In a desert.
Yeah. We're not looking to supplement what they already have or replace what they've already had. We're looking to make what they have better. And I think we do that by having the access to specialists and the technology that they don't have access to.
What might we be missing here as we're kind of like looking at that dynamic tension of rural, urban, and are most West Virginians getting the health care they need?
It's a good question. It's a fair question. I think our current healthcare system is flawed, and it is very hard for independent operations to survive just because of the dynamics involved with physicians, with technology, with legal, with compliance, that we can share those infrastructure costs among our health system. Whereas if you're an independent operator, that falls on your shoulders. And so our healthcare financing system makes it very hard for the independent provider or independent hospital to survive long term. And so that nature of being able to react with scale and economy is very important.
To say WVU Medicine dominates West Virginia healthcare is an understatement. This is especially true in the northern part of the state. The Eastern Panhandle is crowded with multiple health systems, including WVU Medicine. I mentioned this to Mike Hassing. He's the president and CEO of Shenandoah Community Health. It's a federally qualified health center based in Martinsburg, a town on the edge of the Eastern Panhandle bordering Maryland. The Shenandoah Primary Care Clinic in Martinsburg offers a wide range of services like pediatrics, internal medicine, dental, and behavioral health. I was surprised when I pulled into Hassing's clinic and saw a WVU medicine facility nearby.
Yes, several of them.
Right.
And you also saw several Valley Health facilities, all less than a mile from this building where we're at, okay? Valley Health and West Virginia University have multiple brick and mortar facilities. There's urgent care, there's a major hospital, there's primary care, there's orthopedics, you just go on, okay? I mean, it's just, we're in this medical mile, if you want to call it a medical mile.
Well, okay, if I'm somebody living here in the Martinsburg, West Virginia, or the area surrounding, that's a good thing, right? I mean, that I have a good amount of options of healthcare. So having West Virginia University Medicine and Valley Health close by, how does that impact you?
Well, it's great to have those other services so close by. Because when we're looking to try to refer out for specialty services, guess what? We've got specialty services that are just right around the corner.
That's not a 2-hour drive away.
It's not a 2-hour drive away. So what a huge advantage to all of our patients for that. The disadvantage side of it is that it's the competition. Now, competition isn't always bad. Competition is good because it makes you really focus in on the things that are most important. Customer service, all right, patient care. I mean, taking care of the folks. But with the competition, it's a lot easier for the WVUs and the Valley Health to be able to recruit additional doctors and staff and to pay them more and to provide them with a more robust support system, et cetera, than what we have to offer. So it just makes it a little bit harder for us then to be able to work in that arena.
Looks like there's cooperation, but also tension between the general medicine of community providers and high-end specialized hospital care.
It's this delicate and crazy dance that we do where on one side, it's like we really need you because we need you as the hospital and we need all of the care that you provide in your system. We need the anesthesiologist. We need the birthing center. We need to have that here. And they want to support it. But at the same token, as soon as they start investing more into it, that starts taking away from what we're doing. And because we don't have the deep pockets that the other organization has, we're more susceptible then to that, and we just can't sustain it long term.
A key element in this dynamic is health insurance. Hassing says when a large health network comes into an area, people who have health insurance tend to go there. On the flip side, these big companies only see a few of the patients who are uninsured or on Medicaid. Hassing says that creates an expectation that the local community health center will care for the uninsured and underinsured patients in the community.
That's your job. You get a grant for that. The grant's not unlimited. We don't have unlimited resources, so we take care of many of them. But there's this burden that's shifted over to the health center.
Are you suggesting that there might be where the larger organizations say, okay, we're just going to take the people who have health insurance, and they kind of get the patients who are easier to deal with, and they're certainly easy to get paid for your services, as opposed to these others who are tougher to deal with, and it's difficult to get paid for your work?
What you just described is right at the core of what I was trying to talk about. Many of these people just have so many different issues to deal with. It just makes it very difficult for them to have what we might consider to be a normal day. You look at the statistics, okay, and they will show you that people that live in poverty and people that live without a lot of resources have a lot of other coexisting conditions that they have to deal with, okay? They've got food scarcity. They've typically got untreated disease because they're making a decision between going to the doctor and paying for a doctor visit or buying milk and bread for the family. That's a horrible choice to have to make. And there's this thing that the health center is oftentimes seen as the little clinic. Once someone gets health insurance or starts making a little bit more money, then they will, quote unquote, graduate. And it's this whole idea that the bigger clinic, the big hospital, has more services. They must be better. They must provide higher quality care. I get to move up in life. And so it's kind of a social status that...
Well, I need to remind you that the name of my program is Us and Them. And in a way, you just kind of described what could be an us and them divide.
There is a division between the poor people's clinic and the clinic that will serve the rich people, okay? If you want to say it that way. I mean, I want to be careful on how we characterize things, but there is definitely a difference in the psyche, in the mental image of people when they think about a community health center is oftentimes thought of as a second-rate type of an entity versus a larger system.
Earlier, I mentioned that 3 West Virginia hospitals had folded within the first few months of the pandemic. We already talked about Fairmont. Bluefield Regional Medical Center in Bluefield, West Virginia has also shut down. This city has 10,000 people. The hospital was the top employer in the county with about 350 jobs. A statement on the hospital's website says a drop in patients and the stresses from COVID-19 and insufficient reimbursement from Medicare and Medicaid forced the shutdown. Another community hospital from the nearby town of Princeton has stepped up to offer temporary emergency services in Bluefield. About 2.5 hours northwest of Bluefield, a town on the border with Kentucky, also lost its hospital during COVID. After about 100 years in the community, Williamson Hospital in Mingo County is out of business.
Well, the closing of Williamson Memorial Hospital it's a definite deficit in our community because we're an hour and a half away from Charleston, an hour and a half away from Huntington.
That's Dr. Donovan Beckett. Everyone knows him as Dino Beckett. He knows Williamson probably better than anybody. He grew up here. After medical school in West Virginia, where he specialized in osteopathic medicine, he came back to Williamson in 2003 and opened a private practice. At that time, Beckett says doctors were leaving West Virginia in droves. Legal liability issues were pushing doctors out of business altogether. The economy in Mingo County was once based on coal mining and suffering from a long, grinding downturn. Many families were poor and sick.
In our area, we have lots of health conditions such as diabetes, hypertension, coronary artery disease, COPD, a lot of physical injuries from manual labor, those types of things. So it was a basic primary care practice, but we were pretty heavily in diabetes, coronary artery disease, and hypertension, obesity.
In 2011, Beckett opened a free clinic once a month in his offices. It grew in frequency and size. And a few years later, he turned the practice into a nonprofit, the Williamson Health and Wellness Center. He became the medical director and CEO. When Williamson Memorial Hospital closed, Beckett saw it as an opportunity to expand. He bought the hospital for just over $3.5 million. When Beckett opens the hospital, it will be an extension of the Health and Wellness Center.
I'm a physician first and foremost, but I'm also the CEO. To me, I think that's a secret sauce to why we've been able to be successful is because I get to hear every day when I'm seeing patients what are the real-time problems and how that can be, from a physician and an administrator, how we can work those instead of having the dichotomy and different thought processes. Me being able to bring those two together, it just, for me, makes it easier to see through that and then bring that to the board to be able to help bring on new programs.
Williamson is a city of about 3,000 people. However, the Williamson Health and Wellness Center's service area includes 50 to 60,000 people from several counties. The majority of the center's patients are low income and uninsured. As a nonprofit federally qualified health center, the government subsidizes a percentage of the center's overhead costs.
But we also see patients and we generate revenue from seeing those patients. So what we do with that money is we reinvest that back into the clinic, but also we feel that Williamson Health and Wellness is the economic driver for our city, and we're pushing to help develop more opportunities for the people that live in the area.
Over the years, Beckett has forged a reputation as an innovator. Mingo County was a food desert, so he did something about it. About a decade ago, he started a local food program that's still going strong. It includes a traditional farmers market, but also provides produce boxes for low-income patients or those with underlying health conditions. On Saturdays, a mobile unit delivers food to people in remote areas. In 2011, Beckett created the Mingo County Diabetes Coalition. Patients in the program receive education and visits from community health workers. Beckett says the program really works. Patients are able to control their diabetes. Costs are down. The successful program has become a model that's being replicated in other counties and states.
So if we were able to take a patient and keep them out of the emergency room and a hospitalization, you basically employed one of our healthcare workers. So it's a very easy decision for somebody that's looking at our program to see how they could improve their healthcare costs. When you look at the amount of success we were able to have and translate over that whole diabetic population, it's an amazing cost reduction.
Beckett is still working on reopening the Williamson Hospital. Thankfully, there are relatively few cases of coronavirus in the area. However, during the first months of the pandemic, the Health and Wellness Center, like most other health facilities, lost money from a drop in patients. Its 100 employees have kept their jobs, but they've had to work fewer hours.
I always take the elevator.
Recently, patients like Cornelius Murphy started coming back to the center.
Hell yeah.
Murphy's 58 years old. He used to work in construction.
They laid me off, laid everybody off.
Murphy says he found out he had diabetes 3 years ago. He was in and out of hospitals and nearly went into a diabetic coma. Despite his frequent trips to the emergency room, he says nobody told him how to manage his illness.
The doctors there didn't do anything for me. They didn't tell me how to take my shots or nothing. I was all confused. So I was doing everything wrong, trying to listen to other people. And a friend of mine told me about the Wellness Center. My friend got me an appointment over here, and that's how I heard about it.
Murphy lives in Logan. He has a 45-minute drive in a borrowed car to get to the Williamson Health and Wellness Center. He used to have appointments 3 times a week. Now he needs to come just once a month or so.
My diabetes did help me so much. It's under better control now. I prefer to come here because they work with me. Everything's here. Eye doctor, foot doctor. I don't have to go everywhere else, Charleston or Huntington, or out the way to see a doctor. Everything's here that I need.
As a part of his diabetes care, health workers stay in close contact with Murphy to support his treatment plan.
And I love them for that. When I met these people here, I start crying. I'm a grown man. I start crying. And I mean, that was a good feeling. And since I've been coming, I still feel that way. They call me 2 times a week, check on me, see am I eating right, do I need any medicine, if I can make it to my appointment. I love this place. I tell everyone about this place.
Murphy's success story is similar to another patient I spoke with, who has to cross 3 different mountains to get to the Williamson Health and Wellness Center. That's in addition to the efforts Dr. Dino Beckett's team makes to check in by telehealth or in person. It's no question that telehealth will help keep many health systems going around the state. But being here in Williamson makes me wonder about a few things. First, how realistic is a telehealth revolution here, when so much of West Virginia is rural and beyond the reach of the internet? And when my old friend Doug Kaufman at WVU Medicine talks about the necessity of scale in order to survive, I wonder if all of that power and massive footprint is the answer, the too big to fail theory. But on the other hand, look at what Dino Beckett is doing in Williamson. At a time when health systems are hemorrhaging money because their patients aren't coming in and don't have insurance to pay, his community-based health system is already treating those sicker patients with fewer resources. I'm guessing if scale is the name of the game, maybe we need to consider both ends of the spectrum. Maybe hyperlocal, small-scale healthcare is an important part of the answer, too. The truth is, just about everyone in West Virginia can access some kind of health care. In most cases, the question is, how far do I want to travel, and how will I get there? Still, hospitals are in deep financial trouble across the country. That's especially true for rural hospitals. Dr. Dino Beckett may be able to save the Williamson Hospital, but how many Becketts are out there? Is contraction of the country's health systems inevitable? Some say yes. When I first met up with Doug Kaufman from WVU Medicine, he told me about a study saying 15 years from now, each state will have only 1 or 2 health systems. And he says WVU Medicine plans to be one of those few health systems that survives. Many small community health clinics make the case that they should be in business too. The healthcare providers that do survive the pandemic's economic crisis will be instrumental in defining the future of our country's healthcare system. You've been listening to Us and Them. Our team for this episode is me, Trey Kay, Marisa Helms, and Kate Smith. Special thanks to Kyle Vass for helping us gather some of the audio for this show. Michael Lipton and Tristam Lozow wrote and performed the Us and Them show music. Mark Lerner designed our logo. Lelena Price provides us with images for the web. The marvelous people at PRX and West Virginia Public Broadcasting make Us and Them possible. So do grants from the Corporation for Public Broadcasting, the West Virginia Humanities Council, and the CRC Foundation. This episode is supported with a grant from the Claude Worthington Benedum Foundation. Us and Them was originally developed with assistance from the Mentorship Program at AIR, the Association of Independents in Radio. Stay healthy, everybody, and we'll see you next time on Us and Them.
Support for this podcast comes from the Corporation for Public Broadcasting.